My name is Aaron Wilkins. I'm an SVSU MSOT alumni, and I am currently working as a full-time occupational therapist at Lakeland Regional Hospital within their inpatient rehabilitation program. I didn't necessarily choose inpatient rehab. I originally started at a skilled nursing facility, and it was not lining up with what my ideal view of occupational therapy was. So I looked to branch out and applied for the position at Lakeland Regional Hospital and was given the opportunity to come on as a full-time OT. But since being within the inpatient rehab program, it is exactly what I imagined my job being when I was going through the program at SVSU. A typical day within my setting starts at 8 o'clock. I get to the hospital and I do chart review for the day, identify who might be on for treatments for the day, if there's new evaluations, discharges, or progress notes. We have a short team meeting where our team lead comes in and gives us updates based on nursing report for the day. So if there was any medical changes, if there were new admits to the floor. And then after that meeting, then we run off for treatment, and I generally see 3 patients in the morning, and then we have team conference from 11:30 to generally 12 o'clock. Sometimes it runs to 12:30 depending on how many patients we're reviewing. I get a short lunch break where I get to enjoy my lunch while also choosing to do some documentation, and then I see 3 patients again in the afternoon, and then the last half hour of the day is reserved for documentation and prepping and planning for the upcoming day. I think there are a lot of things that make working in my specific inpatient rehab facility unique. One of them being that the 6th floor, which is where our inpatient rehab is located, we have a nursing staff that is dedicated solely to the patients that are on our floor. We also have 3 rehab doctors that oversee the patient's care while they're in the rehab facility. But we're also still connected to the hospital, so if there are any changes in medical status, we can communicate directly with nursing and the doctors to reach back out to neurosurgeons or orthopedic surgeons to have questions answered, or if we have concerns, we can always bring those concerns to nursing or the doctors, and they can make referrals or recommendations based on what they are seeing. So we could initially send people back to the hospital side of things if they had a major medical change, which is one of the things that I think is unique about my position. I think another unique draw to our inpatient rehab facility is we have a vector suspension training system. It is a device that connects to a harness, which can offload patients' weight to increase either their weight-bearing tolerance or help them with no device mobility. So if they want to walk without a walker, but they're not steady enough to do it on their own, it also gives us the flexibility to do some higher level dynamic balance and safety awareness training with our patients. We are the only facility, I believe, in the area that offers this suspension training system, and I think it brings a unique dynamic to what we can do with our treatment options. Caseload for me as a full-time occupational therapist, there are 8 rooms that I am responsible for. All of the rooms are individual based, so there's no split sharing of a room, so each patient gets their own individual room, which has not only their hospital bed, but various tables and recliners and things that the patient can sit in, so it almost simulates like a home setting. Within the bathroom, there's a sink, a toilet, and a shower, so everything is easily accessible. There's a lot of privacy, and it helps promote a sense of independence for our patients. But my general caseload is 6 patients a day, depending on what our census is. If we're at a full census, I will see 6 patients a day, maybe a 7th patient for a shorter period of time. My treatment sessions are generally 1 hour each, with the occasional 30-minute treatment session as needed. and all patients have a certain set number of hours that they have to meet each week. So if we have a patient who is medically unstable and they're not able to participate in therapy at any particular point in time, we can always go back and look and see if there are other patients that have missed time, and we can go to their room directly and do treatments with them so that we can ensure that all of the patients are receiving the highest quality of care possible. A typical evaluation at my inpatient rehab facility generally is allotted for 60 minutes. Within that 60 minutes, I try to gather as much information about who the patient's living with, what their environment looks like at home, any potential barriers that might prevent a safe discharge, at least at this current point in time. And then after I gather information about what their household looks like and what kind of assistance they may have and any potential barriers, then we move into more of the functional assessment. So I try to gather as much information about bathing, dressing, eating, oral hygiene, and those kind of daily activity goals. But outside of gathering that information, some of the assessments that I use on a regular basis are the ARAT, which is the Action Research Arm Test, the 9-hole peg test, manual muscle testing, and the hand grip and pinch grip strength dynamometers. A typical treatment session at my inpatient rehab facility will generally range between 30 and 90 minutes based on what the patient's needs are at that particular point in time. So generally, it is consistently an hour of time that you're looking to treat. So I will go to the patient's room, identify what we're going to work on that particular day, and then move forward with the treatment plan as needed. So if we're working on ADLs, we're going to generally be staying in the room to ensure that the patient has the privacy that they need in order to feel comfortable in performing some of those more private tasks. If we're working on something more mobility-based or dynamic balance-based, we have a therapy gym where we can go down and there is various forms of equipment and things that we might need. There's also various different assessments, and we also have printouts and handouts that we can provide to the patients to ensure that they have the home exercise program that they need, or if we are giving them recommendations and we don't want them to forget, we have handouts on different pieces of equipment and things that we're going to be recommending down the road. So treatment sessions can generally be performed either in the room, or we can come down to the therapy gym where we have a wider variety of tasks that we can complete. But treatment sessions can be as simple as doing a general ADL task, and it can be as complex as doing a medication management task. So it just depends on what the patient that you're working with needs and what the plan of care is asking for. Discharge planning might be one of the most important aspects of my job. Since patients are generally with us between a week and 3 weeks, within that time period, it is of utmost importance that we identify certain barriers that might prevent the patient from going home, whether it's an environmental barrier such as the doors not being wide enough for a wheelchair or walker to fit through, what kind of assistance they're going to be having at home, if there's even going to be anyone to help them, and identifying other safety concerns that might be a barrier preventing the patient from going home safely. So even though it doesn't seem like it, I start discharge planning on day 1. So identifying what barriers might prevent my patient from going home, and then throughout the week to 3 weeks that my patient is with me, we are constantly discharge planning. So earlier, I had mentioned something about team conference, and we generally have team conference Monday, Tuesday, Wednesday, and Friday, and it's when all of the therapists, nursing staff, and the rehab doctors all come together and discuss the patient's care thus far, how they're progressing medically, any barriers that might preventing a safe discharge home, and then the therapists talk about how the patients are progressing physically, and do we think that they're going to be able to go home safely, and if not, we try to problem solve together as a team the safest place or safest discharge option for that patient at that particular point in time. Now, based on how long the patients are with us, they might get one care plan meeting where we're identifying that they're going to be able to go home independently, there's no barriers to safe discharge, and we can move forward. Now, patients who are a little more involved or have a more complicated discharge plan, or if we have them for longer, it gives us more time that we can adapt and change to how that patient is progressing and moving forward in their care. So if there's anything that's preventing them from going home physically, we can discuss those barriers and then problem solve together how we can prevent or move forward with getting that patient home safely. If it's something medically that's preventing it, everybody collectively tries to problem solve a way that we can safely get them to their next step, whether it's home, whether it's with a family member, whether it's to a different facility for a short period of time. Whatever that patient might need, we are constantly planning for discharge. As I discussed before, a majority of my documentation are daily notes, so describing things that might have happened during a regular treatment session. We have evaluations which come through as the new patients come into the inpatient rehab facility. Progress notes, so generally if a patient's been under my care for a week, after that first week we do a progress note so we can track progress, we can update goals, and make changes to the plan of care as we see fit. There are also discharge notes that we have to do once the patient is getting ready to discharge home or to whatever setting they're safely going to be able to discharge to. And within that discharge note, we go over any last goals that might need to be achieved and try to get a real sense of what the patient's current function is prior to them discharging to whichever their setting is going to be. My inpatient rehab facility does want you to keep a productivity rate above 75%. So that means 75% of the time you're at work, that time is being spent seeing a patient, which is something that is billable. So generally our patients are able to tolerate their 3 hours of therapy every day. There are things that do prevent us from achieving our productivity standards, which don't generally happen frequently. But if a patient has a change in medical status and they are not able to tolerate their 3 hours of therapy every day, and we miss an hour, generally we can make that hour up with a different patient. So our productivity never really dips. There's always opportunities to increase and exceed the minimum standard. But on a daily basis, they want us to maintain a 75% productivity rate. My inpatient rehab facility gave a 90-day training period where I was working closely not only with another occupational therapist, but I also shadowed the physical therapist, the speech language pathologist. I worked closely with nursing and the doctors in that 90 days to learn not only the everyday flow of what it's like to be an occupational therapist in the setting, but learning how to perform point of service care and what the different forms of documentation were, what items were required and what items were not within each of the pieces of documentation. I think after the 90 days where I was supervised and provided supervision, I think it was plenty enough to make me feel comfortable within the setting, but I don't think I actually felt the most comfortable until month 4 or 5. And most of that was just with things that were on day-to-day tasks. So I never really had any exposure in my fieldwork experience where I was required to have point-of-service documentation. And so I do struggle with that a little bit. But other than that, within the role of OT, identifying where things were within the building, treatment planning, and those kinds of things, within the 90 days, I did feel comfortable in performing the duties that were required of me. I think as a new grad, it's important to identify what population you want to work with. Being within the inpatient rehab facility that I'm at now, I learned very quickly that there's not one set diagnosis or one set injury that comes in that we see consistently or frequently. It's constantly changing, and it's always a learning experience. Not every stroke that comes in is going to present the same. It's not going to be treated the same. And getting exposure to a wide variety of different deficits that a patient might have is definitely challenging day to day. But I think overall, it's a challenge that I'm willing to accept. as long as you keep an open mind and you're willing to learn and ask questions, there shouldn't be any reason preventing you from practicing successfully within an inpatient rehab setting. As a new grad, if you're looking to go out of state, so I did both of my level 2 field works down in Florida because I knew I wanted to move to Florida. So I identified early on that it was important that in doing those experiences, I gained exposure within the state that I wanted to practice in. So as a new grad, if you plan on going to a different state and you plan on practicing within that state, I would recommend that you do at least one of your level 2 field works within that state, so you can identify things that might be barriers. For instance, in Michigan, I don't think that you need a certification for your physical agent modalities. In Florida, you do need that certification. So things are going to vary state to state, but the best way to gain experience and exposure to what practicing within that state is going to be like is to actually do your level 2 field work there. It also gives you an opportunity to meet and build relationships, not only with your clinical educator or instructor, but also gain exposure in building those interdisciplinary relationships as well. It's not always about what you know, but who you know. So getting to build those relationships within a state that you're potentially going to be practicing in, I think is a very important thing that shouldn't be undervalued.